Uh, Good day, everybody. We continue on the second part of our talk about family planning and contraception. We discussed certain issues in the first part. We are going to go in detail on some of the issues being mentioned earlier on in the first part and to include other methods. So, the hormonal contraceptive, we say they could be either combined or progesterone only. So we'll talk in detail about the combined oral contraceptive pill, which is one of them, combined oral contraceptive pill. It contains both estrogen in the form of ethinyl estradiol and progestogens. The estrogen varies from 50 to 50 microgram. Sometimes you hear about the mini pill. The mini pill contains 30 to 35 microgram of estrogen. The lowest dose pill or the lower dose pill, which is contain only 15 microgram of ethinyl estradiol, is less effective in the control, on the control of the cycle, and also associated with breakthrough bleeding. That's to say, bleeding in between the cycles. So if the pill contains a very low dose of estrogen, the likelihood of bleeding is there. Progestogens used fall broadly into three groups, as I have mentioned earlier on some of them. These are the three groups. The easiest way is to say first generation, second generation, and third generation. First generation, norethindrone. Second generation, levonorgestrel. ده اللي بنستعمله في المايرينا. Third generation, gestodine, isogestrel, norgestimate. This is the third generation. And as we have mentioned earlier on, third generation of progestogens are associated with an increased risk of vasovascular thrombosis. So these are the combined, this is the combined pill with the estrogens in it all the time, ethinyl estradiol and progestogen, which is either first generation, second generation, or third generation. Here you can see the combined pill. Usually, we say that women take them for 21 days, followed by 7 days free of medications, and then bleeding will occur during these 7 days. And immediately after the 7th day, you start on the second course. Or sometimes you get everyday pill. That's say they don't stop. And here it is the same. The 21 days contains hormones that prevent or that act as contraceptive, while the other 7 days using placebo tablet. And you can see it here. These are the 21 tablets containing the hormones, and these white are the placebo. You start usually from the green one here. You go around it. You follow, or the lady follows the arrow, then coming back, going to this, and then reaching the 21st tablet. Then they start the placebo. An important point about them is that the combined pill could be monophasic, in which every pill in the packet contains the same dose of steroids. And from the start, it contains, for example, 30 microgram of ethinyl estradiol and a certain amount of progesterone. They continue all the 21 days. But they could be biphasic or triphasic. That's to say, the content of a hormone in it varies. That's mainly to simulate what happens in the normal menstrual cycle. And as you can understand, in the normal menstrual cycle, the hormone varies. Initially, low dose of estrogen. Estrogen increases gradually. Ovulation takes place. Progesterone being released in a small amount, gradually increases till the onset of the next cycle. So biphasic or triphasic, they try to simulate this pattern. That's to say, the dose in the tablets varies either twice or three times. The idea, as I said, the phasic pills reduce the total dose of progestogens and mimic the normal cycle. And in the first half, we don't need to give progestogen, we know in the cycle because it's not there. Estrogen is there. In the second half, then you can give progestogens. So this is the contraceptive pill, how to be taken 21 days, 1 week, 1 week drug-free, or everyday pill, 21 day hormones and 7 placebo. It could be monophasic, biphasic, or triphasic. So that is the pill. Next combined one is the transdermal. And transdermal is the patch. This is the patch here being put on the shoulder of the lady. It contains both still. Contraceptive patch measures 20 square centimeters, contains both ethinyl estradiol and the second or third generation. This is the third generation of progestogens. So this patch contains both estrogen and progestogens. How it works? It lasts for 7 days. That's to say, after 7 days, you have to change it. The 3 patches will be used consecutively with a placebo patch or patch-free interval in week 4. Same as the pill. 3 weeks on, 1 week off. That's the drug. That 1 week could be without any form of medication or could be with a placebo. That's true also for the contraceptive patch. And thus, contraception protection lasts for about 10 days. This is why we give it every week. Then the last week, it will be patch-free or placebo patch. So this is the second group of combined contraceptive methods. After the first few cycles, the bleeding patterns and side effects are similar to the combined oral contraceptive pill. This is about the transdermal patch. The other method that contains both is the vaginal ring, the combined contraceptive vaginal ring. This is how it looks. It will be put into the vagina, the combined contraceptive vaginal ring, trade name Nuva ring by Organon, releases both ethinyl estradiol and etonorgestrel, third generation of progestogen. So contains both. The ring itself is made of soft ethinyl vinyl acetate copolymer. It has an outer diameter of 54 square millimeters and cross-sectional diameter of 4 millimeters. So it fits on the cervix to prevent it. It lasts for 3 weeks with a 7-day ring-free interval. Same like the pill, same like the transdermal patch. The incidence of irregular bleeding is significantly less than the combined oral contraceptive pill. Now, we mentioned the side effects of all of them. So you'll find that some of them are causing less side effects, other than causing more side effects. The ring here is significantly less side effect compared to the combined oral contraceptive pill. The fourth group is the injectable combined one. Once per month, contains 25 milligram hydroxyprogesterone acetate and estradiol cypionate. Injections are administered intramuscularly every 28 days. This is the combined few الاثنين. لاحظوا ان في injections later on we'll come to it, few one only. Here the injections contain both. So being injected once every 28 days, bleeding and pattern efficacy, and are comparable with the combined oral contraceptive pill. Bleeding episodes can be anticipated 18 to 21 days after the injection. Bleeding is induced by a decline in estrogen concentration to 50 picogram per ml or less. Like the same normal menstrual cycle, estrogen becomes less, then the withdrawal bleeding takes place. The risk has the kernel combined oral, injectable, patch. They couldn't combined. Risks: the third generation progestogens, زي ما ذكرنا early on, increase the risk of venous thromboembolism, especially in obese women and in women with a history of pregnancy-induced hypertension. So here, the third generation we use has that disadvantage or this risk. Also, it's being noted that the combined oral contraceptive pill increases the risk of ischemic stroke, especially in smokers and hypertensive. Here we talked about the third generation. Here we are talking about the combined one, increasing the risk of ischemic stroke. Current users of combined oral contraceptive pill have an increased risk of breast cancer. There is an increased risk of cervical cancer, adenocarcinoma among users. لاحظوا ان احنا قبل قلنا الاوفيرين واليوتراين cancer are reduced when using the contraceptive pills. Here, the cervical cancer may increase, leading to a specific type of cervical cancer called adenocarcinoma. Combined oral contraceptive pill reduces the risk of ovarian and endometrial cancer, is what I have mentioned. So the combined reduces the risk of cancer in the ovaries and the uterus, while they may increase the risk of cancer in the cervix, causing adenocarcinoma. They can also lead to venous thromboembolism, the third generation of progestogens, or they could lead to ischemic heart disease or ischemic strokes. Absolute contraindication to the combined oral contraceptive pill. اللي هي دي World Health Medical Eligibility Criteria Group 4. Category 4, absolute contraindication, you should not use the combined oral contraceptive pill. That's to say, in the following condition, you should not use the combined oral contraceptive pill, but you can use other methods. Somebody with hypertension, absolute contraindication. Current or history of deep vein thrombosis or pulmonary embolism. She had it now, or if it was early on. Major surgery with prolonged immobilization. You shouldn't use the combined oral contraceptive pill. Current or history ischemic heart disease or stroke, whether she had it or whether she is having it now. Migraine with aura, current breast cancer, and diabetes over 20 years with vascular changes. So these are absolute contraindications. Hypertension, current or history of deep vein thrombosis, surgery leading to prolonged immobilization, history or current of ischemic heart disease, migraine, current breast cancer, diabetes, and breastfeeding. In the first 6 weeks, if she is breastfeeding, we try to avoid the combined oral contraceptive pill, and we give the lady progestogen only pill, because the combined oral contraceptive pill is known to reduce the milk secretion. Progestogen only. Our previous talk is about the combined one. So now we are going to talk about the progestogen only. Progestogen only avoids estrogen or includes the following categories: progestogen only contraceptive pill, injectables, implants. Please note that the injectables could be combined or progestogen only. The patches are combined. The implants are progestogen only. So progestin only contraceptive pill, orally, injection, implant, and the important one is the intrauterine system. Contains progestin only, ودي for 5 years, a needle myrena. So oral, injectable, implants, or inside the uterus, all could be progestin only. The mini pill or progestin only pill, as I have mentioned, we usually use it, especially if the lady is trying to breastfeed for the first 6 weeks, and then they can go to the combined oral if she wants to. The mini pill, the older types contain a very low dose of second generation of progestins and inhibits ovulation inconsistently. As I have mentioned, there are 3 generations of progestins, first, second, and third generation. The old pill contains second generation. The new type of progestin-only pill called Gerozet contains the third generation of progesterone, which is disogestrel, in a dose to inhibit ovulation in almost every cycle. So note, second generation of progestogens inhibit ovulation inconsistently, irregularly, while the third generation progestogens inhibit ovulation completely and in every cycle. This is the pill. So we go to the injectable ones. Injectable progestin only. Types available long-acting injections of norethistyrone enanthate. Non-ethistyrone enanthate or depot medroxyprogesterone acetate, DMPA, or Depo-Provera. This is it here. The trade name is Depo-Provera. So these are the available ones. Depo-Provera is given by deep intravascular injection, 150 milligram for every 12 weeks. This is Depo-Provera, containing depot-medroxyprogesterone acetate. It worked for 3 months. Norethistyrone enanthate is administered every 8 weeks. The one here. Norethistyrone enanthate works for 8 weeks, while the Depo-Provera works for 12 weeks. This is being given, this is the drug, this is the medical practitioner giving it to the lady, deep intramuscular injection. So then come to the third group, subdermal implants. We talked about the combined, والآن بنتكلم عن البروجستين only. It could be pill, it could be injection. Third could be subdermal implants or implanon, the generic, the trade name بتاعه. Contain single rod containing 68 milligram or 3 keto disogestrel, providing contraception for 3 years. So it's an implant containing progestin only, and equally it is a long-acting reversible contraceptive method. So implanon, initial release rate of 60 to 70 microgram per day. لاحظنا فيها 68 milligram. That stays for about 3 years. Initially, it starts releasing 60 to 70 microgram per day quite regularly, falls gradually the release to 25 to 30 microgram per day at the end of the 3 years. So the first part of it is a bigger dose or bigger release into the female body, while as it comes to its end of the 3 years, the release will be less than what it is. Implanon preloaded into a sterile disposable inserter, and then it is inserted subdermally on the inner aspect of the non-dominant arm above the elbow. So look at this description. Already it comes in a preloaded sterile disposable inserter. You insert it and then you throw the inserter to be put in the non-dominant arm. Most of the people are right-handed. The left hand will be the choice. Few people could be left-handed. Then the right arm is the one to be used. Then above the elbow and in the inner aspect of the arm. It's inserted and removed using local anesthesia. This is how it looks. This is the implanon. This lady is the right-handed, so this is the rods inserted here. This is the rod, how it looks before being inserted. This lady is probably left-handed and being inserted above the knee, above the elbow joint, I beg your pardon, above the elbow joint and inserted on the inner side of the arm. You can see it here, same. And this is the physician inserting it above the elbow using local anesthesia. Introduce the inserter. Once it is in the right place, you withdraw the inserter and you leave the implanon inside. It works for about 3 years. The fourth group of progestogen only is levonorgestrel intrauterine system, or the Mirena. Levonorgestrel is the progestogen being inhaled. So this is the Mirena, how it looks. This is how it looks. Contains the medications there. Then here is being inserted into the uterine cavity, how it fits. The Mirena, or levonorgestrel intrauterine system, contains 52 milligram of levonorgestrel, leprogestogen only. Releases 20 microgram per day for at least 5 years. So intrauterine device staying for 5 years, releasing levonorgestrel, which is progestogen only, and it continues for about 5 years. The insertion is similar to the copper intrauterine device. We'll see in a minute, because copper does not contain any hormone, the copper device. Here we are talking about those that contains progestogen only. Licensed for the management of menorrhagia. As we have alluded to earlier, it reduces or it affects the endometrium, causing endometrial atrophy. So if it causes endometrial atrophy, there won't be menorrhagia. The bleeding will be very minimal. At the end, it could end into amenorrhea. So cases or patients with menorrhagia, we used to treat them by medications, and if medication fails, we go for major surgery, which is total abdominal hysterectomy, laparotomy or laparoscopically. Nowadays, we can use the levonorgestrel intrauterine system, or Mirena, to treat ladies with menorrhagia, to cause atrophy of the endometrium and stop the bleeding. Also used to deliver the progestogen component of HRT, as I mentioned earlier on. If a lady had a Mirena in the uterus, then you can give her estrogen alone, because the progestogen component is inside the uterus being released from the Mirena. So progestogen only contraceptives, how do they act? Different modes of action. Depo-Provera injection, implanon implant, Gerazet, third generation of oral progestogen only contraception. These inhibit ovulation at 3 day. Depo-Provera, implanon, and Gerazet. Low dose preparations and old ones inhibit ovulation inconsistently. So nowadays we are using mostly the 3rd generation or sometimes 2nd generation of progestogens. And I explained to you in the first talk what do you mean by 1st and 2nd generation. All progestogen only contraceptives affect the cervical mucus, reducing the sperm penetrability and transport. All except the Mirena have an effect on the endometrium, compromising implantation if ovulation occurs. While the Mirena had marked effect of the endometrium, making it atrophic, little action on the ovary. So some of them prevent ovulation, some of them prevent ovulation inconsistently, the progestogen only contraception. They affect the cervical mucus, affecting the sperm penetrability and transport. All except Mirena affect the endometrium to the state or to a stage whereby implantation will not take place if fertilization occurs, or if, yes, ovulation occurs or fertilization. The Mirena goes a step further by making the endometrium atrophic, and thus there will be no implantation at all. So this is a mode of indication and contraindications, talking about the progestogen-only contraceptives. Breastfeeding mothers are advised to use progestogen-only contraception as estrogen impairs the milk production. We have mentioned that. Progestogen-only contraception is prescribed for women in whom estrogen is relatively or absolutely contraindicated, like cardiovascular disease, migraine, diabetes, hypertension. Here, the estrogen is absolutely or relatively contraindicated. So we use progestogen-only pills. This is the relative contraindication or indication with WHO medical eligibility criteria 3, where the harm outweigh the benefit. So here we use the combined oral contraceptive. Sorry, here we use the progestogen-only contraception, just to correct. In this situation, we use progestogen-only contraception because there is a relative or absolute contraindication for estrogen. Side effect of progestogen-only contraception. لاحظ أن we talked about the combined one. Now we are talking about the progestogen only, defining what types of progestogen being used, in what form could it be, is a film, is an oral tablet, could be implants, could be intrauterine system. Side effect of all this could be amenorrhea, commonly occurring with the Mirena. Unacceptable bleeding usually occurs after insertion of an intrauterine contraceptive device, whether the Mirena or the copper. Usually in the first few days and weeks, there is irregular bleeding, which may not be accepted by the patient, but eventually it settles. Persistent follicles or follicular cyst, we have mentioned that. Other hormonal side effects generally, headache, nausea, bloating, breast tenderness, weight change, mood change, the one we have mentioned them earlier on. They could also come with a progestogen-only contraception. Delay in resuming fertility in case of Depo-Provera that can go up to 1 year. If one has stopped Depo-Provera, when Depo-Provera contains progestogen only. Here, the delay or the time to pregnancy could take about 1 year. Another group is the intrauterine devices. We talked about the Mirena, اللي هي الميرينا ذات intrauterine device, لكن it contains hormones. This one does not contain hormone, and this is the one being used also, which is copper containing intrauterine devices. This is the device, how it looks. This stent contains the copper. In the arms here also there is copper. Here how it looks inside the uterus, how it fits inside the uterus. There is a tail for it here coming through the cervix. When one wants to remove it, you just pull through the tail. That is also in the case of the Mirena. So copper containing intrauterine devices amount of copper varies between 250 to 350 square millimeter. Some of them at least 300 millimeter of copper have the lowest failure rates. Others, devices containing 250 millimeters are licensed for 3 years, containing 250 millimeter square. The safe T or the T safe copper 380A contains copper in a larger dose, bigger than this one. This is licensed for 8 years, while the lowest containing one is for 3 years. What we are using now is the T-Safe copper 380, commonly used in the market, and that could go up to that period of time. The others are licensed for 5 years. So if you are using anyone in this range, it is for 5 years. Lower than 250 for 3 years. More than 375 or 380 for 8 years. An action of or mechanism of action for intrauterine contraceptive device. Here we are talking about the one that contains copper, not the Mirena. Here, stimulate a marked inflammatory reaction in the uterus. This leads to increase in the concentration of macrophages, leukocytes, prostaglandins, and various other enzymes in both uterus and tubes. المارت inflammation بيطلع لنا macrophages, leukocytes, prostaglandins, and other enzymes. These products are toxic on both the sperm and the oocyte and interfere with the sperm transport. If fertilization occurs, they inhibit ovulation. Normally, fertilization should not occur. Insertion should be within the first 7 days of the cycle, and removal should be in the luteal phase in the first 7 days of the cycle. In late luteal phase or in the first 7 days of the cycle, insertion and removal. Being inserted and removed by a medical practitioner. This is their action. How do they act? Contraindication, the IUCD, intrauterine contraceptive devices, اللي هي category 4, absolute contraindication. History of malignant trophoblastic disease. You should not use an intrauterine contraceptive device. Malignant trophoblastic disease, you could use the pill after the beta HCG comes to normal level. If there is endometrial cancer, if there is pelvic tuberculosis, if there is current sexually transmitted infection, women with HIV/AIDS can use the copper intrauterine device, but should be counseled about safe sex. It is important. Because obviously the male could use a condom, but the woman could use the device, but the device does not protect against HIV infection. So absolute contraindication, malignant trophoblastic diseases, endometrial cancer, pelvic tuberculosis, or current sexually transmitted infection as an absolute contraindications for the progestogen-only pills. That's not the progestogen-only pill. It's for the intrauterine device. I beg your pardon. So intrauterine contraceptive devices side effects. They could cause menstrual disturbances, as I have mentioned, after insertion. Some of them do have this disturbance of menstruation for a period, and then eventually it settles and become regular, or it could lead to amenorrhea completely if you are using the Mirena. Dysmenorrhea side effect, pelvic infection is increased, especially in women with multiple partners. Actinomycosis-like organisms are seen in some smears, perforation at the time of insertion, and expulsion. That means being expelled out and had a failure rate whereby pregnancy could occur while the lady is unaware that the intrauterine contraceptive device has been expelled. So side effect, menstrual disturbances, dysmenorrhea, pelvic infection, actinomycosis like organism, perforation of the uterus at the time of insertion, and expulsion and failure of the IUCD occurring in 1 in 20 of women having it. The risk of ectopic pregnancy is reduced compared with women using no contraception. And I talked to you earlier on about the risk of ectopic pregnancy, but you have to be aware that if you take it generally, women using intrauterine contraceptive devices have a less prevalence of ectopic. But on the other hand, if pregnancy failed or if the method failed, the likelihood of the pregnancy to be ectopic is there. And I hope these statements are clear. Women not using contraceptive devices more likely to get ectopic than those who are using contraceptive devices, the IUCDs. While if it failed, a pregnancy could occur, and if it occurred, could be ectopic one. You go to the barrier methods. Male and female condoms, diaphragm, and cervical caps. They work preventing the passage of the sperm into the female genital tract. Male and female condoms, not deposited there, or deposited on the cervical and the diaphragm, will prevent the sperm reaching the ovum. Male condoms reduce the risk of STDs and HIV/AIDS, the one we have just mentioned earlier on, just to put it again. Diaphragms and caps, cervical caps, must be fitted by a health professional. Condom doesn't need any health professional. Diaphragm and cervical caps should be fitted by a health professional. And the male condom reduces the risk of HIV/AIDS and sexually transmitted diseases. Just to conclude our talk about the other contraceptive methods, now we talked about hormones, or hormone combined and progesterone only. We talked about non-hormonal, these non-hormonal intrauterine contraceptive devices. Also, we talked about the long-acting reversible contraception, they could be hormonal or non-hormonal too. We talked about the injection long-acting contraceptive devices, whether it contains both hormone or one hormone. We talked about the patches. We talked about the implanon, and we talked about the intrauterine contraceptive devices, whether it is copper or Mirena. There are other methods that could be used. These are natural methods for fertility awareness, lactational amenorrhea, emergency contraception, and sterilization. I'll go quickly on them to conclude our talk. This is sterilization, starting on it. These are the tubes here. This is the laparoscope affecting the tube here. This is the tube here. This is the fallopian ring. You can use the fallopian ring here, or you can ditherm it and cut it. This is the vasectomy, getting the vas deferens, cutting it, so the sperm being produced in the testicle won't reach the seminal vesicle to be stored there for ejaculation or for release after ejaculation. This is sterilization. Natural methods to avoid intercourse during the fertile period of the cycle. Periodic abstinence, avoid intercourse at all. And you have to calculate the fertile period of the cycle. The cycle has to be regular. This will not work in an irregular cycle. Cycle has to be regular. Then you calculate the fertile period in a cycle, regular 25 to 31 days. Ovulation, the first day of fertility period, is calculated as the length of the woman's shortest cycle minus 20 days. This is the roughly calculated so. The last day of the fertile period is the longest cycle minus 11 days. So you use this time to calculate, and then this is fertility awareness avoided. Generally, we say in a lady who's 28-day cycle, ovulation day occurs on day 14. So you're avoiding intercourse early on, 2 to 3 days, then 2 to 3 days after the release of the ovum. Sorry, the release of the ovum now. Natural methods, also looking at the cervical mucus. In the follicular phase, the mucus becomes clear and stretchy, allowing the passage of the sperm. After ovulation, due to the presence of progesterone, the cervical mucus becomes opaque, sticky, and less stretchy. بنسموها thin bulkhead phenomenon. The intercourse must stop when the fertile type mucus appear. So if the mucus is thin, then and stretchy, this is a sign that ovulation has taken place or is going to take place, and accordingly, intercourse should be avoided in that particular time. So you could either calculate or you can look at the cervical mucus. We can use the basal body temperature in the pulse, ovulation, and progesterone secretion associated with a rise in basal body temperature by about 0.5 over degrees Celsius. It's used to be in the pulse. We don't do it now. Failure rate of all methods, natural methods of fertility awareness, is very high, the failure rate, due to conscious rule breaking. That's to say, intercourse consciously taking place at the time of the fertile period. And thus, the method won't be effective. The other one is lactational amenorrhea. Breastfeeding delays the resumption of fertility after childbirth. The delay is related to the frequency and duration of breastfeeding periods or episodes. Prolonged breastfeeding postpones ovulation and risk of pregnancy for more than 1 year. I'll say this statement and come to it. In developing countries, women breastfeeding longer and the potential use of lactational amenorrhea method is much greater. But it is associated with a pregnancy rate. Just to summarize this slide, there is lactational amenorrhea, no ovulation is taking place while the woman is breastfeeding, and especially if she is breastfeeding the fetus or the baby, very frequently and for a longer duration. But we must know that in some cases where the lady is breastfeeding, ovulation could take place in spite of the amenorrhea. I say it again. In women breastfeeding, ovulation could take place in spite of regular breastfeeding, and thus she could conceive without having a period. So it shouldn't be used as a reliable method. Though we know in developing countries it's being used and it works for some time, but it is associated with a failure rate. So the one before the last is the emergency contraception. You will hear this term. What does it mean? Defined as any drug or device used after intercourse to prevent pregnancy. Device or drug. Levonorgestrel is taken as a single dose within 72 hours of intercourse. So the intercourse has taken place, no methods being used, then levonorgestrel could be used in a single dose within 72 hours of the intercourse. Inhibits or delays ovulation if taken in the early mid-follicular follicular phase, there is no evidence that it inhibits implantation. So emergency contraception, when the intercourse has taken place without a method being used, or if the lady forgets to take the tablets, levonorgestrel is given in a single dose within 72 hours. It works if it's being used that way, and though it's not known to prevent ovulation. Emergency contraception can be used to prevent pregnancy if sexual intercourse without protection, normal contraception fails, like the condom splits during the act of intercourse, missed one or more tablets, contraceptive pill, vomiting or diarrhea while taking the pill, missed the injection. So these are the situations where the emergency contraception could be used. In the case of intercourse without protection, if the condom fails or splits, if she missed more than one or more tablets, contraceptive, if there is vomiting or diarrhea while she is on the pill, if she missed the injections. So this is the last slide, I believe. Provision of information and informed consent or informed choice for the lady. You give her the information, you give her all the necessary information, she then decides what to do. These could be the information to be given to the lady, contraceptive efficacy. Whatever method she used, you have to tell her as a medical practitioner that this method is effective for so and so and so. Then the duration of use, for how long, the risk and possible effects, non-contraceptive benefits, failure rate, fertility retained after stoppage of contraception, the procedure for initiation and removal or discontinuation, whether it is removed an intrauterine contraceptive device, ولا patch, ولا implanon, whether she wants to discontinue. So how to do that? All these information should be given to the lady in the first counseling sitting, and then she have an informed choice what to take. Can take the combined oral contraceptive pill, or progestogen only pill, or long-acting reversible methods, whether that's containing hormones or does not contain hormone. I think this should be the last slide. When to seek help also if she is using a method. So thank you very much. And we give actually to be a very brief, comprehensive, containing a lot of information about family planning and contraception being used and side effects, complications, method of insertion, be available now in the market. So we hope that will be quite informative to you. Thank you very much. So we finish our talk, and thank you very much. I hope it was helpful and useful to you. Thank you very much.